Hi class. In this lecture, we will discuss drugs used to treat thromboembolic. The objectives are listed on the slide, and they're also listed in your Blackboard module. Pertinent vocabulary is listed here. Definitely be familiar with these terms. So before we begin talking about the drugs for thromboembolism, I'd like to start with a case. And I'll thread this case throughout this entire lecture, and it's going to come up especially when we talk about some of the most important anticoagulants like heparin and warfarin. So since this is pharmacology class, we're going to focus mainly on her drug therapy throughout this case, but I urge you guys to think about other nursing care that would be pertinent for her that you should be providing. So first things first, she is a 53-year-old African-American female. She presents to the ED with a chief complaint of difficulty of breathing. Her past medical history includes chronic kidney disease stage 2, diabetes type 2, hypertension. Her height is 5'4" and her weight is 145 pounds. And so let's review her current medications. And just so you guys know, as I look through this list, one of my very first questions is, do these medications make sense based on her past medical history? So you guys should all be looking at this list and first of all figuring out, well, what drug classes are these? What indications would these medications be used for? And then from there, you want to think about whether they make sense or not given her history. You might think about, are there any drug interactions? And then probably most importantly, think about whether any of these medications could be causing her current symptoms. So her current medications are aspirin, 81 milligrams by mouth once a day. Aspirin in this case is likely being used as primary prevention of coronary events given her history of diabetes and hypertension. She's also on lisinopril, 10 milligrams by mouth once daily. Lisinopril is an antihypertensive drug. It's an ACE inhibitor to be specific, and it can be used for treatment of hypertension, and it's an especially good choice in patients with diabetes because it can provide some kidney protection. So given that she's got diabetes and chronic kidney disease, lisinopril is a good choice for an antihypertensive. She's on metformin, 500 milligrams by mouth twice a day, and that of course is for type 2 diabetes treatment, and then she's on a multivitamin. So again, thinking about these medications and trying to figure out whether or not any of these medications could be causing her symptoms once you have a good feel for what they're used for. So as I mentioned, Ms. Bleeden presents to the JHH emergency department and she says she's having trouble catching her breath and she's coughing up blood. So what questions do you think are appropriate to ask at this patient to investigate those symptoms in relation to her past medical history? So pause the tape for a moment, think through what kind of questions you might ask, and then we'll talk through some of the examples. So these are some example questions that you might ask. There are probably a lot more than what I have listed here, but things like, when did these symptoms begin? Does your breathing get better upon rest? Are you having pain associated with those symptoms? If yes, where is that pain located? Have you tried to take anything to relieve the pain? Has it been helpful? And then additionally, you might ask about medications. So not just the medications that you already know about and whether or not the patient's actually taking those, but also over the counter or even complementary and alternative medications as well. And like I said, there are lots of other questions that could be asked, but these are probably some of the questions that we would start with to try to figure out what's going on with the patient. All right, so let's move on to the drugs. We'll come back to our patient kind of as we're discussing some of the different drugs. There are three broad classes of drugs that we're going to talk about, and then within each of those classes there are a couple different drugs, specific drugs that we'll review. So we're going to talk about anticoagulant drugs today, antiplatelet drugs, and thrombolytic drugs. Each of these three affect the hemostatic system, but they do so in different ways. Anticoagulants reduce the formation of fibrin by disrupting the coagulation cascade. These drugs are best for venous thrombosis, um, and basically they work either by inhibiting the synthesis of clotting factors, that's what warfarin does, or they inhibit the activity of clotting factors, such as heparin, for example, inhibits the activity of clotting factors. So there are four different groups of drugs that are considered anticoagulants. Those that activate antithrombin, so unfractionated heparin and low molecular weight heparin, direct thrombin inhibitors such as dabigatran, vitamin K antagonists, warfarin, I'm sure you've all heard of warfarin, direct factor 10A inhibitors such as rivaroxaban. The antiplatelet drugs, the next group, all of these drugs inhibit platelet aggregation. And because of that, they're best suited for preventing arterial thromboses. And then finally, the thrombolytics. By the way, the thrombolytics are also called fibrinolytics. And that's because they promote the lysis of fibrin. And in doing so, they cause the dissolution of thrombi. So we're going to talk about each of these drug groupings, and then we'll talk about each of the classes within those groups. So let's start off by talking about the anticoagulants. And the first group we'll talk about are the drugs that activate antithrombin. So there are two drugs that activate antithrombin, unfractionated heparin, or UFH. By the way, in clinical practice, you will hear most people refer to this drug as heparin. That's just the common term. The most appropriate term would be unfractionated heparin, or UFH, but most clinicians just call this drug heparin. The other drug is, actually there are several, it's a group of drugs called the low molecular weight heparins, or LMWH. Both of these drugs greatly enhance the activity of antithrombin. So let's talk about unfractionated heparin, or heparin, first. Mechanism of action, heparin binds to antithrombin. And this actually produces a conformational change in antithrombin that greatly enhances its ability to inactivate factors. You may remember I mentioned antithrombin when we were talking about pathophysiology, and I mentioned that this is the physiologic molecule that inactivates these factors, particularly when the factors start to stray away from the site of vessel injury. This drug neutralizes two specific factors, 2A and 10A. And so you can kind of see what happens. I have a little diagram at the bottom of your slide. You have antithrombin, and then that little chain that you see is heparin. And so basically, unfractionated heparin will bind to antithrombin, and that increases antithrombin's affinity for binding those factors such as 10A and thrombin, essentially kind of amplifies that process. Heparin itself has a very quick action, a fast onset, and it has a short duration as well because it has a pretty short half-life. It's about 1.5 hours. This drug is used for prophylaxis and treatment of DVT and PE, so deep vein thrombosis and pulmonary embolism. It is the drug of choice for pregnant patients that require prophylaxis or treatment of DVT and PE. It's also used in procedures, so procedures like open heart surgery, ECMO, which is extracorporeal membrane oxygenation. Essentially, the drug is used to prevent coagulation in the devices that are used during these procedures. Can also be used for DIC, which is disseminated intravascular coagulation, or can be used as part of the overall treatment for MI. This drug is given parenterally only. So it's only given IV or sub-Q, and that's because it cannot be absorbed from the GI tract. The most concerning adverse effects associated with heparin and frankly every single other drug we're going to talk about in this lecture is bleeding. Some of the common sites, if the patient has a trauma site, GI tract, urinary tract, or pharynx, treatment options. So the good thing about heparin is that it has a short half-life. So if the patient is experiencing significant bleeding, in many cases you can just stop the infusion and within an hour or so, the bleeding, the drug will wear off and the bleeding will cease. So for most patients, that is sufficient. However, sometimes it's not sufficient. Maybe the patient has some kind of underlying issue that's increasing their risk of bleeding. Maybe they've got hemophilia or some other underlying problem. They also could have potentially been overdosed with heparin. That's probably the most likely reason for a patient who receives heparin that's unable to stop bleeding. In those cases, stopping the infusion may not be sufficient, so the patient might need a transfusion. They could be transfused with whole blood or fresh frozen plasma. In addition, there's a reversal agent that's available, and that drug is protamine sulfate. I should have bolded this on the slide. That's a very important drug. You guys absolutely have to be familiar with that drug. And so this drug is used essentially 1 milligram of protamine sulfate will reverse 100 units of heparin. Heparin is dosed by units. And so most hospitals, in fact, I would say nearly all hospitals these days, will have explicit guidelines about how to reverse the effects of anticoagulants. Within the last 5 to 10 years, there's been a very broad focus on anticoagulation, especially in the inpatient setting. The Joint Commission, which is the organization that accredits hospitals and other healthcare institutions, and so that group required, as part of their national patient safety goals several years back, that hospitals have reversal guidelines in place. So I would venture to say that pretty much any hospital that you guys end up working in will have pretty concise guidelines about what to do. So those guidelines will indicate when to stop the infusion, when you might need to transfuse the patient, when you might need to use the reversal agent. They'll even have guidelines about how to use the reversal agent, because protamine can be dangerous in and of itself. This drug can actually cause fatal hypotension if it's given too rapidly. And so wherever you work, I would say one of the first things you should do is become familiar with the guidelines that your institution uses for reversing the effects of anticoagulants, including heparin. So by far the most important thing that you need to know in reference to adverse effects for heparin is bleeding and kind of how that would be managed. Some additional adverse effects that should be mentioned: osteoporosis is possible. It's rare, but it is possible. Sometimes you have patients that require prolonged anticoagulation with heparin, and so, and when I say prolonged, I mean greater than 6 months, and so those patients could be at risk for osteoporosis. This drug can also cause spinal or epidural hematomas. So patients who are anticoagulated that are going to have spinal or epidurals placed or pulled could be at risk for hematoma, which is very serious. This drug can also cause thrombocytopenia. Now there's a mild type of thrombocytopenia that we don't get too concerned about, and that's called heparin-associated thrombocytopenia, or HAT. Happens in about 10% of patients. The mechanism is non-immune mediated. And the reason I mention that is because the second type of thrombocytopenia, which is called HIT, or heparin-induced thrombocytopenia, is very serious, and that type of thrombocytopenia is immune mediated. So for the heparin-associated thrombocytopenia, or HAT, occurs within several days of heparin initiation. Platelets usually have kind of a mild decrease, but they remain above 100,000. And they often, over the course of a couple days, return back to baseline. Now, as I said, there is a second type of thrombocytopenia, heparin-induced thrombocytopenia, or HIT, which I'll refer to it for the remainder of the lecture. This occurs in about 1 to 3% of patients. It is immune-mediated, as I mentioned. It usually occurs about 5 to 7 days after the drug is started, and it's very serious. In patients who experience HIT, their platelet count drops below 150,000 or greater than 50,000 reduction
50% reduction from baseline. And the reason why HIT is so concerning is because it is associated with heparin-induced thrombocytopenia with thrombosis. And this is life-threatening. So in about 50% of patients, despite the fact that these patients are thrombocytopenic, they actually are at high risk for developing thrombosis. And that's because heparin complexes with a normally occurring molecule called platelet factor 4, which essentially is an antibody that's formed against the body. And so this antibody actually stimulates platelet adhesion, and it can result in thrombosis and skin necrosis. And it can have up to a 50% mortality. So it's very, very, very serious. And this is just a diagram of kind of what's going on. As I mentioned, this is an immune-mediated process. This immune complex occurs when the platelet factor 4 and heparin bind together. Platelets start to kind of aggregate. Procoagulant particles are released, and this is what really leads to thrombosis and why heparin-induced thrombocytopenia is so concerning. So the way we treat HIT, and this is one of the most important slides in this lecture. Please be familiar with this slide. This is important because, first of all forms of heparin have to be discontinued. Otherwise, the patient's platelet numbers are just going to continue to drop, and that is in response to all of the platelets basically aggregating together. So all forms of heparin, even flushes, have to be stopped. And the patient is going to need some other form of anticoagulation. DTI is a direct thrombin inhibitor. We're going to talk about those in a few moments. So that's an appropriate drug. That's the most common drug that would be used to continue anticoagulation for these patients who are experiencing HIT from heparin. Another drug that could be used is a factor Xa inhibitor. If the patient's on warfarin, it has to be discontinued until platelets recover. Once warfarin is restarted, it should be overlapped with the other anticoagulants, such as the direct thrombin inhibitor, for at least 5 days. And the reason why is because these patients are in a prothrombotic state because of the HIT that's occurring. And if you stop their anticoagulation, warfarin takes several days to start working. So in that interim, when warfarin's not working, if they're not on another type of anticoagulation, they're at very high risk for clotting. So warfarin and the other drug, usually a direct thrombin inhibitor, should be continued for at least 5 days. And one thing to note, direct thrombin inhibitors actually increase the INR. We'll talk about this when we talk about warfarin. Warfarin is monitored by the INR. So for these patients, your INR has to be higher than what we would normally see because the direct thrombin inhibitors artificially inflate that INR. Very important point. I bolded it. I put it in red. You need to know this. Patients who have HIT should never get heparin again. Any heparin. They shouldn't get a flush. They shouldn't get unfractionated heparin. In fact, they really shouldn't even get low molecular weight heparin, which we'll talk about in a few moments.
So moving on, let's talk about individual variation that's of importance with unfractionated heparin. So first of all, patients with a high likelihood for bleeding, such as patients with hemophilia, active peptic ulcer disease, or head trauma. And there are other examples. These are just some of the examples of patients that would be at risk for bleeding. Those patients, we would be very cautious using heparin in any of those cases. And for many of those, we may not use heparin at all. We also worry about severe liver or kidney disease, and that's because heparin is primarily removed from the body through hepatic metabolism, but renal clearance also plays a role. So for patients with either severe liver or severe kidney disease, the dose that they'll need for heparin will likely be lower than other patients. So we're very cautious in that setting as well. There aren't a lot of drug interactions that we worry about with heparin, but we certainly worry about heparin when it's used with other drugs that either affect platelet function or other anticoagulants. So medications like NSAIDs or aspirin can impact platelet function, and then any of the other anticoagulants that we talk about in this lecture, if they were used concomitantly with heparin, it would be of concern. Monitoring, so for heparin, we monitor therapy very closely. Remember, the objective of anticoagulant therapy is to reduce blood coagulability to a level that's low enough to prevent thrombosis, but we don't want that level so low that we promote spontaneous bleeding. Now, heparin, as I mentioned earlier, the response to heparin is highly variable from patient to patient. So monitoring of heparin therapy is very carefully undertaken, and it requires assessment of coagulation to guide therapy. So there's not a standard dose that we use and then we just go with that. We initiate a dose, and then after several hours we monitor blood coagulation tests to determine whether or not adjustments are needed, and this is done in an ongoing fashion until the patient is in what we call the therapeutic range. So first and foremost, baseline labs need to be assessed, and this is to assess the patient's hemostatic function at baseline. So the labs that would be assessed are the APTT. The APTT is the activated partial thromboplastin time. So we would look at that before starting the heparin infusion. We also look at the PT-INR. PT is prothrombin time, and the prothrombin time is normalized to the INR, which is the International Normalized Ratio for the PT. So we would look at that level as well, again, to assess baseline hemostatic status. We'd also look at a CBC, so we want to look at platelets at baseline, as well as hemoglobin and hematocrit. And then finally, BMP, or just basic metabolic panel. And so remember, I said important individual variation for unfractionated heparin is liver or kidney disease. So by looking at the basic metabolic panel, we can assess those. So that would be done at baseline, and those would be obtained before starting the heparin infusion. Now, ongoing labs. So after 6 hours, an APTT would be drawn, and the APTT is reported in terms of seconds. So the normal value for an APTT is 40 seconds. But when heparin is therapeutic, the heparin will increase the APTT by a factor of about 1.5 to 2. So that makes the normal range somewhere around 60 to 80 seconds. The thing you need to know is that it is variable by the lab reagent that is used. So every hospital is going to have potentially have a slightly different APTT range for what they consider therapeutic. So the dosing nomograms that are provided at the hospital level will include that detail as to what is considered therapeutic for the APTT at that particular hospital. And I'll show you some examples of that in a few moments. Now, sometimes, rather than the APTT, or in conjunction with the APTT, sometimes another test is also done, and that's called the anti-10A unfractionated heparin activity. And this is reported in international units per mil. The reason why this test is sometimes used is because there are some physiologic conditions that make the APTT unreliable. And so in that setting, the anti-10A unfractionated heparin activity can be used. In some cases, we use them in conjunction because neither one or the other is absolutely perfect in all scenarios. I guess kind of the take-home point here is that probably what you'll see is the APTT used to monitor heparin and adjust heparin therapy, but in some cases, in some hospitals, you may see the anti-10A unfractionated heparin activity used. And then the other ongoing lab that is very important is a CBC. So again, CBC because we want to look for potential bleeding, but also mostly for platelets because remember, unfractionated heparin in a small percentage of patients, they could develop heparin-induced thrombocytopenia, and so we have to monitor platelets very closely to identify if that has occurred. So let's talk about nursing implications. There are a lot of nursing implications with unfractionated heparin. Of all the drugs you learn in this class, this one is right up at the top of the list of medications that are risky, without a doubt, that have extensive nursing implications. You must look at your textbook and review all of the nursing implications that are in the nursing implications section of your textbook for heparin. We have pulled out many of the most important points, but you still need to go back and look at those nursing implications. So let me talk through some of the highlights. Administration points. First of all, at almost every hospital in the United States, and in fact, I'm going to go out on a limb and say at every single hospital in the United States, there will be nomograms to guide heparin initiation, titration, and monitoring. And this is in a large part because the Joint Commission, many years back, I think it was around 2008 or 2009, required that hospitals have very strict guidelines in place for managing anticoagulation, because anticoagulation is risky and because it's error prone. So wherever you work, when you complete your program, you want to be familiar with those nomograms to guide therapy. Now, the heparin could be nurse managed, meaning that the provider writes an order and says, we would like to implement nurse managed heparin, and then there is a very detailed guidance document for that nurse to manage that heparin therapy. Or the therapy could be prescriber managed. And what that means is that the prescriber will order the heparin drip, and then every 6 hours will monitor the APTT and write new orders to adjust therapy accordingly. Just so you guys know, there is a good deal of data that says nurse-managed heparin is superior for some patients, or for many patients, and the superiority lies in getting patients into the therapeutic range quicker, as well as avoiding complications. So I think that most of you, if you work in the inpatient setting, will be most likely managing, or guiding these nurse-managed heparin nomograms for your patients. We're going to do a little example of that in a few moments, but let me talk through the rest of the nursing implications. For patients who are on anticoagulation, such as those on heparin, they should not receive medications via the IM route because that can increase the risk of hematoma. Some safety considerations. Heparin is a highly risky medication. One of the reasons for the high risk is that it's available in many strengths, from as low as 10 units per ml all the way up to 20,000 units per ml. And these different strengths are stocked in the pharmacy. Hopefully the strengths that are stocked on the nursing unit will be minimized, but you certainly can be in a scenario where pharmacy stocks the wrong concentration on the unit. You may be expecting 10 units per ml, but what's stocked in your automated dispensing cabinet could be 1,000 units per ml. So you have to be very careful when you are obtaining heparin doses and administering heparin doses. Furthermore, heparin infusions or even boluses will always be administered on a smart infusion pump. I would think that it would be very, very unlikely for you to work in a hospital where heparin is not programmed through the smart infusion library. Some patient education points, and again, these are just some of the very important points, but there certainly are others, so please be sure to refer to your nursing implications in your textbook. But identifying or educating patients to identify symptoms of bleeding, and in fact also symptoms of thrombosis. And you should be looking for symptoms of bleeding while you're managing these heparin infusions. Patients need to avoid over-the-counter NSAIDs because they can increase the risk of bleeding. Patients need to use electric razors or soft toothbrushes. Again, these are just ways to minimize bleeding risk. Now, for the most part, heparin infusions are going to be administered in the inpatient setting, But there are scenarios, like I mentioned when we talked about therapeutic uses, where heparin could be given subcutaneously for prophylaxis, and that could be done in the community setting. So some of this patient education would probably be more likely to occur with those prophylactics sub-Q doses. When you are managing these strips in the inpatient setting, you'd still talk to patients about patient education, but it would really be more managing those patients. Obviously, you would be managing, looking out for symptoms of bleeding, but you could engage the patient in that process as well. So getting back to our patient case. So Ms. Bleeden, we already talked about her past medical history and talked about kind of what her chief complaint was. Ultimately, she was diagnosed with a PE. And now she's been admitted and transferred to your unit, and you're going to be taking care of her. The prescriber has ordered a heparin infusion, and they have ordered that via the nurse-managed standard target UFH nomogram. So at Johns Hopkins, that is the terminology that they use. For the nurse-managed heparin, they have multiple nomograms. Those different nomograms could be ordered, and they would be ordered based on patient-specific variables, such as indication, such as bleeding risk. So, lots of things will go into which specific nomogram would be ordered. At Hopkins, they have the low target nomogram, the standard target nomogram, the high target nomogram, and the post-surgery nomogram. I'm not going to go into the details for every one of those nomograms. If you're interested, you can go on the public workstation homepage at Hopkins, go to the Hopkins policies online, and type in heparin, and that'll bring you up the policy and then all the different nomograms that are associated with that. Our patient was ordered the standard target nomogram, so let's take a look at that and see what that entails. So this is the standard target nomogram. First and foremost, I want you guys to pause the tape and I want you to read through this. This is page 1 of the nomogram. There are 2 pages. I want you to pause the tape and read through this particular nomogram and get familiar with it. Once you're familiar with it, restart the tape and I'll highlight some of the key points of the nomogram. Okay, so hopefully you took a few moments to to kind of look over this nomogram. A couple things to point out. First of all, this is the standard target unfractionated heparin nomogram. If you look at the top of the nomogram, you can see it says standard very big, and the goal range. So this is our goal APTT. Our goal range is 50 to 80 seconds. So that's our standard APTT range that at Hopkins, that would be the standard range. The suggested indications, so patients with AFib, patients with VTE, so venous thromboembolism like a DVT or a PE. Well, this is good because our patient has a PE, right? So this would be an appropriate indication for our particular patient. And then you can see some other suggested indications that are listed. I would say the next important thing would be to look at those contraindications. There are absolute contraindications, so absolute means under no circumstances should this be used if the patient meets that criteria. And then there are relative contraindications, and for those it's going to be based on clinical judgment. So that's going to be a discussion between the provider, potentially multiple providers. If a patient has one of those relative contraindications, the provider might consult hematology for some advice. They would also talk with nursing. They might talk to pharmacy. They might talk to a variety of people in assessing those relative contraindications. But you want to take a look at those, and you want to think about those in relation to our patient, Ms. Bleeden. So does she have any of these contraindications? So in terms of absolute contraindications, she doesn't have a known hypersensitivity to heparin. I did not mention that she has that. She doesn't have serious active bleeding. So we would need to assess whether we thought she had active bleeding. And she does not have HIT. As far as we know, she does not have HIT, but we would want to verify that. In terms of the relative contraindications, so high risk for bleeding, to our knowledge, she's not a high risk for bleeding. I mentioned some of the examples of patients at high risk for bleeding. She doesn't fall into any of those categories. Platelet count. I didn't tell you her platelet count, but we would need to know that. Her current platelet count is 240,000, so she's well above the lower threshold for a relative contraindication. Again, she doesn't have a history of HIT that we know of. We would definitely ask her, or we would look in her chart. Our patient is 54, so she doesn't meet that criteria based on age. You would also want to look at those key points. So I'm not going to read through all of those. I'm just going to highlight a couple. But again, you would need to look through all of these key points. One that I definitely want to point out is number 2, which is bolded. So ensure baseline labs are obtained. In many cases, depending on the unit, the nurse may have to obtain those labs, or phlebotomy might obtain those labs. But nevertheless, the nurse is responsible for making sure that the labs are obtained, and you do not wait for the labs to result. So basically, the labs need to be obtained, and then the heparin infusion can be started. But you don't want to start the heparin infusion before those labs have been obtained. It's very important to get those labs before the heparin infusion is started. And think about that. Why would that be? Why would we need to wait to obtain our labs before starting the heparin drip? And then the next thing, so you guys can look through the remainder of those key points, but then you have to actually walk through table 1 to implement these heparin orders. So first of all, you need to know your patient's weight. Now, I told you guys that our patient weighed 145 pounds, so you would need to figure out what the kilo weight is equal to. And of course, you take the weight and you divide it by 2.2 to come up with your kilogram weight. And then you go on to step 2. Step 2 is important, so there are a couple highlights there. With heparin infusions, sometimes an initial bolus is ordered, and that's because we want to get the patient into the therapeutic range very rapidly. So if we have a patient who has a massive PE, we want them anticoagulated as soon as possible. In that scenario, we would probably give a bolus. And there are many other scenarios that we're not going to get into. But for our patient, let's say that an initial bolus was appropriate and the provider ordered that. So we would look at the patient's weight and determine what our bolus is, and that bolus would be administered. Typically, that bolus is administered over 10 minutes, and it is administered via the intravenous infusion pump, usually straight from the infusion bag. We call that bolus from bag. And that would be documented in the PRN section of the MAR for this particular nomogram. And then we would start the infusion. So again, you have to figure out what your infusion rate is. So you look at the patient's weight, and that will tell you what you would program in terms of your infusion rate. And then that's it. You've started your heparin infusion. And then 6 hours later, we're going to obtain the first APCT, and again, that would be the nurse's responsibility because this is nurse-managed heparin. The nurse will be responsible for drawing or making sure that someone draws that APCT 6 hours after initiation of the infusion, and then the nurse would follow the nomogram, which continues on page 2. So let's take a look at page 2. All right, so this is page 2. Again, there's a lot going on here, so I want you to pause the tape and read through this page, get familiar with it, and then I will walk you through some of the key points of this. So please pause the tape now, and once you've read through this page in its entirety, you can restart the tape. All right, so hopefully you were able to read through this page and hopefully it made some sense to you. So this is the second part of the nomogram. After you have gotten your first APCT, you're going to come to this second page of this nomogram, and that's going to help you figure out what to do. So again, you need to use your same weight that you used for the initial infusion, and once you've got your APCT, you go to step 1, And whichever row that APTT falls in, you'll kind of go across to step 2 and figure out, is a bolus needed? It's really a rebolus, right? Because if there was an initial bolus given, then this would be kind of a rebolus at that point. But you need to figure out how much bolus to give, and that would be based on the APTT, or whether no bolus is indicated at this time. And then you need to move on to step 3 and figure out, what do you need to do with your infusion rate? Are any changes warranted? Does the infusion rate or the infusion need to be stopped? Does the infusion rate need to be changed? And so again, based on that APTT, it will dictate what you're supposed to do in step 3. And then step 4, you're actually carrying out that change. And to figure out what that change is, you again need to know the patient's weight. So across the top in step 5, you can see, you would locate that weight range, and then that would tell you how to adjust your infusion rate based on that weight range and based on what your APTT is. And then step 6, you have to get another APTT. So essentially, what will happen is you will you keep getting your APTT until they're in range, and once it's been in range for at least 2 values, then we would move to getting the APTT once a day with AM labs. So that's kind of the nomogram in a nutshell. I know that was kind of a quick explanation. But what we'll do next is do a little practice with this nomogram. So we have a learning activity, an active learning activity. So here's what I want you to do. I want you to consider our patient, Ms. Bleeden. You can go back to past slides to figure out what her weight is. And I want you to figure out what her initial bolus dose will be. And what her continuous infusion dose will be. And you can assume that a bolus dose was ordered for this particular patient. So what will her bolus dose be? What will her continuous infusion dose be? Tell me what that will be in terms of mils per hour too. Now, the pump will tell you that, but it's good practice to always verify what that mils per hour will be. Actually do that calculation so that you can verify that the pump was programmed appropriately. So tell us what that mils per hour will be, and then let me know when you're going to obtain a follow-up APTT. And I'm telling you that your follow-up APTT that you obtained at the appropriate follow-up time is going to be 48. So I want you to look through that second page of the nomogram and basically explain what you're going to do at that point based on page 2 of the nomogram. So you're going to need to pause the tape at this point. This is going to take you at least 5 minutes, maybe longer. You're probably going to have to get a calculator out. At least for the mils per hour part, you're probably going to need a calculator. But I want you to stop the tape and engage in this active learning activity. And then when you've answered all of these questions, restart the tape, and I will walk through the answers.
Okay, so hopefully you had some time to answer all of these questions. We're going to go through the answers at this point. So the first question was, what initial bolus dose will you administer? So if you look at the nomogram on page 1, you see that there is step 1, step 2, step 3 chart at the bottom of the page. You first need to know your patient's weight. I told you her weight was 146 pounds, so you would convert that to kilograms by dividing it by 2.2. So that would equal approximately 66 kilograms. So in looking at your chart, in step 1, we look at the dosing weight, and her dosing weight would fall in the range of 65 to 74 kilograms. So the first thing would be to go to step 2 and look at what bolus dose she would be given. Now, I said that not all patients will have a bolus, but for our purposes, for our patient, she was ordered a bolus. And if you go across the row, you'll see that her bolus dose is 4,900 units. Now, that bolus dose is typically bolused directly from the infusion bag. We call that bolus from the bag. However, it could be a syringe or a bag that's sent up from pharmacy. Generally, that's administered over about 10 minutes. But again, this pump programming will be done all through the drug library at Hopkins for sure. I imagine anywhere else you work that would also be the case because this is a high-risk drug. So our next question, what initial continuous infusion dose will you program? Again, if you just go across the rows, you go to step 3, and you can see that her initial infusion rate is 1,260 units per hour. And the third question is, what is the mils per hour of the infusion? Now, you will be programming this in terms of units per hour, at least at Hopkins. That is how their heparin is programmed. And you can see if you look up under key points, under number 2, all unfractionated infusions shall be administered by IV infusion pump using the drug library. Heparin is programmed in units per hour for adult patients. For pediatric patients, it will be infused and programmed in terms of units per kilo per hour. So her initial dose is 1,260 units per hour. And then in terms of what the mils per hour would be, this is really just a double check. So what you would do, again, is you'd need to know what your concentration is. I can tell you that all different hospitals can use a variety of different concentrations. Concentrations I'm familiar with are 40 units per mil, 50 units per mil, and 100 units per mil. In pediatric patients, the concentration may even be lower because the dose is so low. So you would need to figure out what concentration your hospital is using. Now again, if you look under key points, under number 3, only pre-mixed unfractionated heparin infusion with a concentration of 100 units per mil are to be used. So the standard concentration that's built into the drug library for heparin infusion at Johns Hopkins Hospital is 100 units per ml. So you would take the dose in units per hour and convert that using that 100 units per mil to figure out what your mil per hour rate is. And if you did the math on that, you would find that your rate is 12.6 mils per hour. When will you obtain a follow-up APTT? So if you look at, again, look at those key points. Number 7, draw APTT 6 hours after initiation of the infusion. So you would draw the follow-up APTT 6 hours later, and then follow the nomogram on page 2. So flip your nomogram over to page 2, and 6 hours later, not 6 hours later, a little while later, it could be an hour, it could be 2 hours later, it depends on the lab and the turnaround time. You will look at your APTT value once the results come back. And for our patient, we said her results were that her APTT was a 48. So now what would you do? So you flip over to that second page and you look at her value. So step 1, you can see that the second row, her value is between 41 and 49. And so going over to step 2, give rebolus if ordered. Remember, she was ordered for an initial bolus. So we do have to flip back over to table 1 to remind ourselves what bolus would be given. Rebolus would be given. And so if you look at the far right-hand side of the chart, you see rebolus if APTT is less than 40, or if APTT is 41 to 49. And so for this particular patient, again going across the row, her rebolus dose would be 2,450 units, half of what her initial bolus was, given the results of her APTT. So again, you would give that rebolus, and then look at step 3. It says stop the infusion. Well, clearly no, that would not be appropriate for her because her APTT is subtherapeutic. And then in step 4, we need to figure out by what amount do we increase our heparin infusion rate in terms of units per hour. So you would travel across the grid over to step 5 and find her weight range. Her weight is 66 kilos, so we would look for the range 65 to 74 kilos, and you can see that that means we would increase her rate by 150 units per hour. So I just kind of click through all those values. So you can see for her, that means that we would increase the infusion to 1,410 units per hour. Of course, that would be 1260 plus 150, and that's how we come up with 1,410 units per hour. And then finally, we need to get another APTT because the patient was not in therapeutic range. And so if you travel on the grid over to step 6, you see repeat APTT in 6 hours. So recheck that APTT in 6 hours. A couple other things to think about. Clearly, there is a lot of documentation going on with the kind of operationalizing of this heparin nomogram. Some of it will be via BCMA, some of it's going to be manual documentation that you'll be doing. One thing to keep in mind is that heparin is a high-risk drug. It's considered high alert. And so if you look up at the top of the dose chart, you can see step 7, obtain second RN to verify infusion changes, and then assign a co-signature to the RN. So there are lots of double checks involved in administering heparin. Other things to think about: the products are going to come from pharmacy ready to use. You should not be mixing any heparin at the bedside. Maybe in an emergent situation that might be different, but I would say by and large, your products are going to come from the pharmacy ready to use. The only exception I can think of is possibly in the operating room or maybe in a procedural area, but even in those areas, we generally have ready to use products available. I think all in all, you can see that this is a pretty complex process. I think that overall, there's really a lot to learn here, so I want you guys to spend some time getting familiar with this standard nomogram. Just so you know, at Hopkins there are numerous nomograms: low dose, high dose, standard dose. Even the standard dose nomogram is broken up into 2 sections based on the patient's weight. So there's quite a bit of complexity, as required given the complexity of administering heparin. Furthermore, there is a lot of monitoring. Labs such as the APTT, vital signs, of course looking at symptoms, bleeding or even thrombosis. So there really is a lot that goes into managing heparin infusions. All right, so let's move on.
All right, so let's move on. Let's now talk about low molecular weight heparin, also known as LMWH.
All right, so let's move on to our next drug, low molecular weight heparin. The prototype low molecular weight heparin is enoxaparin or Lovenox. There are a couple different low molecular weight heparins available in the United States. By far, the most common one that's used is enoxaparin. In fact, most people, when they think of low molecular weight heparin, enoxaparin or Lovenox is really synonymous with low molecular weight heparin. That's how more popular enoxaparin is in relation to the other low molecular weight heparins that are on the market. The mechanism is very similar to heparin. This drug it's basically heparin. It really is heparin. It's derived, so low molecular weight heparin is derived from unfractionated heparin, but it's composed of shorter molecules than those that are found in unfractionated heparin. This drug is actually much easier to give because it's a fixed dose. It doesn't require monitoring the way that heparin does. The plasma levels of this drug are highly predictable. They don't undergo non-specific binding to proteins and tissues the way that unfractionated heparin does. I know I didn't mention that when I was talking about unfractionated heparin, but that's really, there's a lot of patient variability with unfractionated heparin, and that's why we have to monitor it so closely with blood tests. Low molecular weight heparin, on the other hand, because of the way it's formulated, doesn't have that non-specific binding to these various proteins and tissues. So it's a much more predictable drug. It has a longer half-life and duration of action than unfractionated heparin, and it has an improved bioavailability. It is still not given orally. It's still a parenteral drug. It's given via the sub-Q route, and its therapeutic uses are pretty similar. It's used in prophylaxis and treatment of DVT or PE. It can also be used for prevention of those problems for pregnant patients. It can also be used as part of an overall approach to therapy for MI. I think the one thing to point out here is that low molecular weight heparin is generally not used in procedures. So like heart, those procedures I talked about, like heart bypass or extracorporeal membrane oxygenation. This drug is super duper expensive in relation to heparin. Heparin works very well for those procedural type of needs for anticoagulation of the circuit or of the equipment. So for that reason, low molecular weight heparin is not used for those issues. I do have a little diagram on the chart that I want to point out. The mechanism of action, as I said, is enhancing the activity of antithrombin, but low molecular weight heparin only neutralizes factor Xa. And if you look at the chart, you can see why, or the diagram. So you can see antithrombin, and you can see the low molecular weight heparin molecule. It's a lot shorter than the molecule of heparin or unfractionated heparin. And so in this diagram, you can see that antithrombin will bind factor Xa and also bind low molecular weight heparin. Now, in the part 4 of that diagram, thrombin is actually unable to bind to antithrombin in this configuration because that molecule of low molecular weight heparin is not long enough to kind of wrap around the thrombin and facilitate that process like the heparin molecule was able to do. Now, like I said, this is much detailed, much more detailed than what I want you to know. But like I've said to you guys before, I like pictures, helps me remember things. So that's kind of why I went through, the diagram and kind of how low molecular weight heparin works in relation to your unfractionated heparin. All right. Route, I already mentioned this drug is given sub-Q. Frankly, there is some new data for giving this drug intravenously, but it's still not approved to be given intravenously. I think the majority, I would say 99.99% of use of this drug is via the sub-Q route. I mentioned it's very expensive. It's not used as frequently inpatient. It's used much more commonly in the outpatient setting just because it's easier to administer. It has a longer half-life. It can be given twice a day or even once a day, unlike heparin, which needs to be given via continuous infusion. And it doesn't require extensive lab monitoring the same way that unfractionated heparin does. Adverse effects are very similar to those that we see with heparin. Number one, bleeding. So bleeding is the most concerning issue with this drug. Similar to heparin, protamine sulfate can be used for reversal. It is dosed a little bit differently than when it's used for unfractionated heparin, but for our purposes, just knowing that protamine sulfate is an acceptable reversal agent. This drug can also cause HIT. It does not cause HIT to the same, it doesn't have the same prevalence as unfractionated heparin has, but it can cause HIT, and for that reason, patients who have HIT when they're on heparin should not receive low molecular weight heparin. It can also cause severe neurologic injury in patients undergoing spinal punctures or epidural anesthesia. I mentioned this for heparin as well. This is definitely something you guys need to be familiar with. And finally, this drug is cleared by the kidneys. And so for patients with creatinine clearance less than 30 mils per minute, their dose absolutely must be reduced empirically. So that's important to know that this drug is influenced by kidney function. So finally, let's talk about nursing implications for low molecular weight heparin.
So monitoring is a little different for low molecular weight heparin than it is for unfractionated heparin. One thing that's consistent are the baseline labs that we obtain. So just like unfractionated heparin, we need to assess the patient's baseline hemostatic status. So we're going to look at a baseline APTT, a baseline PTINR, baseline CBC, especially looking at hemoglobin, hematocrit, and platelets, and also the BMP. BMP is especially important for low molecular weight heparin because this drug is cleared through the kidneys and does require dose adjustment for kidney dysfunction, even mild to moderate kidney dysfunction. So it's very important to assess and to obtain the basic metabolic panel to make sure that the dosing is appropriate. Where low molecular weight heparin differs from unfractionated heparin is that after baseline labs, we do not routinely monitor coagulation status in order to adjust the dose. Instead, low molecular weight heparin has standard dosing, and that is because there is much less patient variability with low molecular weight heparin. I talked a little bit about that when I was talking about the mechanism of action, so that standard dosing is an advantage to using low molecular weight heparin. Now, with that said, if we do need to monitor coagulation tests, the test that would be used for low molecular weight heparin is different. We would not use APTT. It is not helpful in ongoing monitoring of low molecular weight heparin. Instead, the only test that would be appropriate would be the low molecular weight heparin anti-10A activity. But like I said, this is not routinely recommended. It might be used in special scenarios like pediatrics. Almost always pediatric patients who are receiving low molecular weight heparin, especially if they're less than 40 kilos, they will have serial low molecular weight heparin anti-10A activity drawn in order to monitor their dosing. So that is different, much different from how adult patients are managed. Now, with that said, there are even some adult patients where we might use low molecular weight heparin anti-10A activity, specifically obese patients, and that just has to do with the way this drug distributes in the body. Pregnant patients also, because distribution can be changed in pregnancy, and also just in general, pregnancy in general requires closer monitoring, and also renal dysfunction. So in some cases, for patients with moderate to severe renal dysfunction, if low molecular weight heparin is used, we might also monitor those low molecular weight anti-10A activity levels, just because the drug is not cleared as well in renal dysfunction. But here's the take-home point. For the most part, for the vast majority of patients, we don't routinely monitor coagulation tests on an ongoing basis, specifically to adjust the dose. We will, of course, look at platelets, right, to assess for HIT. We might also look at hemoglobin and hematocrit ongoing, depending on how long the patient will be on the low molecular weight heparin. But those aren't to adjust the dose, those are to assess for adverse effects. So it's a little bit different than what we do for for unfractionated heparin. Of course, we're also looking at vital signs, also looking at signs and symptoms of bleeding, as well as thrombosis. Patient education, that's important. Low molecular weight heparin is used more frequently in the community setting, so it's really important to provide high impact education to your patients so that if they are having bleeding or potentially thrombosis, they contact their provider. So explaining the signs and symptoms of either bleeding or thrombosis is extremely important for these patients. Additionally, since this medication is given via the subcutaneous route, providing them with proper sub-Q injection technique training would be important. That would include things such as rotating injection sites. For this particular dosage form, this is a pre-filled syringe, and it has a bubble that helps with expelling the entire dose. They're not supposed to push that bubble out prior to injecting, so it's a little different from some other medications, but important education point.
as well as other sub-Q injection education that I'm sure you're all familiar with. And then things like using a soft toothbrush, electric razor, avoiding OTC NSAIDs, things like that that are important for any anticoagulation any of the anticoagulants the patient could be on. Those are all important patient education points.